Good morning, everyone, and welcome to Methodologies in Fiscal, Economic, and Health Spending Projections. My name is Mark Goldwine at the Committee for Responsible Federal Budget. I'll be your host here today. I want to thank everyone for joining us, and especially thanks to AEI for hosting this event, which I think is going to be a really exciting discussion on how we project forward our fiscal, economic, and health situation. It's going to feature discussion from AEI's own Mark Warshawsky, as well as the chief actuaries for Social Security and Medicare, and folks at CBO and the Penn Wharton budget model. But before we get started, or as we're getting started, as a housekeeping note, we will be taking audience questions at the end, but you should submit them as you remember, as you think of the questions. You can do that by emailing John Mantis, who has been doing a great job organizing this whole event. His email address is john.mantis@aei.org. That's john.mantus@aei.org. Now, the fiscal situation in the United States has deteriorated substantially in recent years. Just in the last year, the budget deficit, the annual amount we're borrowing, has effectively doubled from $1 trillion last year to something that's going to be about $2 trillion this year. Social Security and Medicare costs have grown about 15% over the last fiscal year. Interest costs are rising rapidly. In fact, this year we're going to spend more on net interest on the debt than everything the federal government spends on children. You know, that includes child tax credit, child health care, education, you name it. In just a couple years, we'll be spending more on interest than on defense. And meanwhile, debt is approaching a record level of the economy. If you take a bit of a longer view, it wasn't that long ago that debt was half the size of the economy. Even prior to the COVID recession, only 80%. We are now headed for a new record. And interest costs, we saw yesterday, have closed at their highest in 15 years, while inflation still remains somewhat elevated. Now, if you think that's bad, our future outlook is even worse. Social Security and Medicare, their trust funds, are both projected to be insolvent within a decade or so. CBO thinks that debt is going to reach 180% of GDP within 30 years. That's under current law, so it assumes a lot of generous things about what Congress does and doesn't do, and they effectively think debt is going to double as a share of the economy to unprecedented levels. Interest is on course within a quarter century to be the single largest federal government program, larger than defense, larger than Social Security, larger than Medicare. And according to a new paper from Mantis, Pang, and Warshawsky, things may actually be much worse than what I just described. I described a mix of data from the Congressional Budget Office and the Medicare and Social Security trustees. But Warshawsky and his team have a new unified model that brings together the long-term fiscal, economic, and healthcare outlook, and actually thinks this situation may be even worse than what I'm describing. We're very pleased to have Mark Warshawsky here today to explain their model and what it's found. Mark is a senior fellow at AEI, and previously he was the deputy commissioner at the Social Security Administration and an assistant secretary at the Department of Treasury, among many other distinguished positions. So at this time, please join me in welcoming Mark Warshawsky.
Thank you very much, Mark, for that kind introduction. And I also want to second thank you to our fellow panelists for their participation and for, as you will see, their very fine and varied comments and presentation as well. And I want to thank the audience in advance for their comments and questions at the end of the event. This presentation will be based on a paper, a working paper that John Mantis, Gaba Peng, and I have produced. And it, as Mark indicated, I think it's somewhat unique in the sense that it is unified, that it combines healthcare spending, the federal budget, benefit programs, Social Security, Medicare, and many other factors into a single model, not a siloed approach, but sort of looking at the interactions among them all. And it does share with the models that the panelists represent a lot of assumptions and a lot of observations and a lot of relationships, but it also makes its own assumptions in certain key areas And as we indicated, it does this integration, which we'll discuss a little bit more as we go on in the presentation. So next slide. Let's just begin as to why we do these long-range projections. It's not by any means not universal. Some countries do not do this, but it is very good practice. And if policymaking were informed by it, it would be provide a more efficient economy, better welfare for the population, because there are certain things that we can anticipate actually with a great deal of certainty. We know about the demographics of the country, what they're doing. There's very little uncertainty about that. And that is in fact the basis of a lot of these long-range models. And a lot of the relationships are very well established and very well known. So there actually is a lot that is known. And if we see problem ahead, it obviously is rational to react to that in advance to try to solve those problems before they develop. It also is a good way of assessing intergenerational equity. Was one generation better off or worse off, and how so? This is not a unique exercise in the United States. Many official agencies do it. As has been mentioned, the Congressional Budget Office does a 30-year model. The Treasury Department does a financial report, which is in essence a projection for over 75 years. And the administration in a somewhat obscure area does a 25-year projection. CMS does both 10-year and 75-year projections of national health expenditures. The 10-year projections get a lot of attention. The 75 years less so, but they're very insightful. And as mentioned, the trustees, both for Social Security and for Medicare, do their 75-year projections, and CBO does a 75-year projection for Social Security. So there's a lot there. They don't all agree. There's certainly tendencies that are common among them. But I think the contribution that we hope to make is that we want to provide a fully integrated model that integrates key relationships of demographics, labor markets, savings, interest rates, healthcare prices and spending, federal budgets, and economic growth. I know that's a lot, but I think it is doable. So next slide. Here's going to be probably one of the most technical slides that I have, but it is the basis of the model. We have two sectors and two factors of production. So the two sectors are what we call everything else, all other, and healthcare services. And the reason why we divide them is for a couple of reasons. Number one, healthcare is now almost a fifth of the economy. And we think it has special characteristics which need to be modeled separately, whereas everything else can be modeled by a traditional Cobb-Douglas production function, which has some substitutability between capital and labor in the production. And it's a very well known and very well modeled formula for production of goods and services in the economy. Probably the key parameter there is what we call G1, which is labor productivity. That really produces increases in welfare for consumers and growth in the economy. And also the other parameter, beta 1, which is determines the share of output that goes to labor and goes to capital. Healthcare services, by contrast, we model as a Leontief production function, which means that there is absolutely no substitution between capital and labor. We feel that this is supported by the literature. It is also supported somewhat by common sense. You observe, let's say, a nursing home. You have a building and you have staff, and there's really very little substitution between the two. You need both to produce the services that are provided to take care of patients. And that, to a large extent, is true in a lot of other areas of healthcare. There is some labor productivity there as well as G3. It is less productivity growth. That is the observation that we made based on some work that the Bureau of Labor Statistics did. And there are these proportions of capital and labor that are needed to produce healthcare output. The total is added up with a price added to healthcare, the relative price of healthcare, which is another key parameter in the model. It's an output of the model, but it's clearly very important in terms of what the government spends on and what consumers spend on in terms of healthcare. That relative price goes up, and we'll discuss why that is so. Next slide. So there are some other key equations in the model. Capital formation. Capital is very important because it is needed for both healthcare and all other, especially for all other. It depends on the depreciation of last year's capital and the new investments that are made. And the new investments that are made, we model as 21% of income of GDP. That's based on historical relationships, but we subtract 0.15 multiplied by the deficit. This actually is a lower bound of the literature's estimate of the impact of the deficit on the money that's available for the economy to invest in capital. The Congressional Budget Office has it at 0.33. There are a lot of other estimates out there in the literature. We're going to be a little conservative and say that there is, with the deficit rising, there is less investment, but not by as much as some other estimates. And then we have equations for what the government spends on and the federal deficit. So the government in non-benefit spends on defense, and it spends on non-defense. The first is proportional GDP. We actually have that at 4% of GDP. And then non-defense spending, which is pretty much everything else that the government spends on, aside from benefits to the population, justice, government administration, and so on and so forth, that we have as proportion to the total population. The deficit is government spending, less taxes that are collected, and then we add the cost of benefits and the cost of interest payments. And the taxes are income and payroll taxes, and benefits are both government healthcare spending as well as Social Security. Next slide. So some other significant assumptions, and these do matter a lot in terms of outcome. And we try to estimate them as best we can, again, based on the literature, based on other models, and based on data. Labor's share of all other output is 63%. It actually has come down over time. It used to be higher. Annual growth in labor augmented technical progress, in other words, labor productivity, is 1.8%. And then for the healthcare sector, labor productivity grows at 0.4%. The tax rates, we have a very simple model. Others do a much more complicated model, but we're modeling, by the way, current policy, or what we think is current policy, what the tendency is. So in terms of taxes, they don't seem to go up much or down over time. I mean, there's a lot of Sturm and Drang about it, but generally they're pretty stable over long periods of time, and we estimate that at 9.8% of income. That's less tax transfers and subsidies. Social Security and Medicare payroll taxes. Again, this is a little more straightforward because the numbers haven't changed much in the last 20 plus years. We model that at 11% of labor income, so that's just applied to wages and salaries. And then what we have here is there's also some benefits taxes that are paid on Social Security benefits. We have that growing at 0.35 percentage points per year. Actually, we already got a comment from Steve Goss that may be a little high, which unfortunately means that there's less taxes coming in. So we'll look at that in future adjustments to the model, but just to keep that in mind, and maybe that the revenues that we have are a little on the high side. Next slide. So we start the model in 2021. We started this project about a year ago, and that was the latest data that we had, and we're actually still missing one little piece of data. So we still start in 2021, and these are the initial conditions, in terms of capital stock for the whole economy at 77.6 trillion, labor hours in the economy, 280 billion, and the GDP, which was 23.3 trillion in 2021. And then looking at the healthcare sector, The capital stock is relatively low. Labor hours are about 10% of total hours. And in terms of output, as we indicated, it's a 4.3 trillion, which is a little less than 20% of GDP. Some other key parameters that we use in terms of demand for healthcare are income and price elasticities. And we have that changing over time. We start at 1.2 for income elasticity. So it makes healthcare a luxury good, but then we do have it decline over time to less than 1. So we have it to 0.9. This is a little more, it's based on what the trustees do for Medicare, but we have it going down a little faster than they do. And this is a very key parameter because it relates to the demand for healthcare as income increases. And we have some sensitivity to prices, and we use exactly the assumptions that CMS uses. So there is sensitivity to prices that higher prices do reduce the demand for healthcare, but not as much as income. Next slide. So we solve, and it's important to note this, we do not assume some key factors in the model. We solve for the relative price of healthcare. Again, here is a somewhat complex equation, but let me just sort of make the points that it's derived from demand, which comes from the demographics. In other words, as the population ages, they spend more on healthcare. These elasticities that we discussed and our spending matrix, which we'll show in a minute. And then we have this relationship between capital and labor and the price of healthcare. Now, just to sort of put it into words, we have an experience that we have Baumol's cost disease. In other words, because healthcare is a less productive sector than the rest of the economy, the relative price of healthcare goes up. Because we are having basically less and less labor growth, the labor force growth is slowing. It actually stops eventually because of the aging population. That puts additional pressure on healthcare prices, and so they actually increase somewhat over the period. And that is a difference, I think, from some of the other models. But it's a key point, and it really does flow out of the assumptions and the way we model healthcare. Next slide. We also solve, we don't assume the real interest rate, and it is also from first order conditions based on the cost of capital. And basically, as capital stocks increase, the cost of capital falls. The government interest rate is directly related to the cost of capital. It's that R less the fixed risk premium. And we initialize that. The way we get our fixed risk premium is we look at the historical last 20, 25 years of the real interest rate for government securities. A little bit of complexity there, but basically it's 1.8%. But the relationship with the cost of capital is 1 for 1. As we mentioned, deficits crowd out investment, as we discussed before. So therefore, growing deficits cause interest rates to rise. And this creates a vicious cycle because it increases the deficit, which means higher interest rates. The government has to spend more on interest, and it can deteriorate. In fact, I think this could be the beginning of a crisis in the sense of if it happens very quickly. But in any case, it certainly happens, and it is a primary driver of budget deterioration alongside the increase in healthcare spending. Next slide. So some other data that we use, we get our underlying demographic projections from the Congressional Budget Office. And as you see in these two graphs, we really don't have much population growth. In fact, according to the CBO, all the population growth comes from immigration. There are actually more deaths than births among the native population, but this still does not produce much population growth. And it certainly produces very little labor force growth that you see in the second on the right-hand side, that you actually have growth in labor force actually coming to a complete halt by 2075. And overall, it's very slow. Next slide. So we have to apply to that labor force, or to the population, I should say, who will be in the labor force. And we basically do something quite simple. We base it on labor force participation and unemployment based on the last 20, 25 years, the experience on average. This, I think, is pretty straightforward. We might perhaps in a future version of this model look at some more labor force participation among older workers, but for now, we think this is a pretty conservative assumption. Next slide. So another sort of very key set of data is the spending profile by age and gender and the source of payment. We relied heavily on the CMS's numbers, which they do every 2 years, and so we relied on 2018. We thought 2020 would be somewhat unusual because of the pandemic, so we relied on the 2018 profile, and we basically forwarded it and blew it up to 2021 aggregates by source of payment. And then we combine this with the population projections and elasticities to estimate demand, as is indicated. Next slide. So these are the numbers. I just, I think they're all pretty straightforward. I mean, there's just a couple of very obvious points. Healthcare spending increases by age, so this is an important part of the projection. For Medicare, it increases a lot, but it's also for the other sources. And also, women spend more than men, a little bit. I think one other thing to note is there's actually a lot of spending on long-term care, which is one of my topics, and you do see it in the data both through Medicaid in the older ages, particularly for women, and also out of pocket, and a bit in private insurance. That is obviously very important in terms of our next slide, which will be the first results. This is our projection of national healthcare expenditures as a share of GDP. We have 3 lines here. One at the top line is our model. The second line is the CMS, projection, assuming no government price controls on healthcare through Medicare or Medicaid. And then the bottom line is current law, which does have some of these price controls. The point about price controls, which we'll come to a little bit later, is as the trustees note, it does imply, at least in the long run, that you will have basically 2 tiers of healthcare provided for the people who depend on government healthcare and everyone else. And whether that's sustainable in the long run is a political and cultural question. I think there is some doubt as to whether it can be sustained, but it is an open question. But it does produce a noticeable difference. But most importantly, between our model and what CMS has, we have more spending because we have less healthcare productivity, and we do have these labor effects that we discussed earlier. As the economy comes into these labor shortages, more and more labor is going into the healthcare sector. It cannot be. It is not used in everything in the other parts of the sector which are more productive. Other sector which is more productive. Next slide. Here are some other projections which Mark alluded to it in his introduction. Federal debt held by the public. We compare ours with the financial report of the U.S. government. We have by the end of the period debt rising to 700% of GDP, which of course is totally unprecedented. I think everyone would agree ultimately is not sustainable. The financial report has 570%. Comparing interest payments, interestingly, we have less, although it goes up very high. We have it going up to 15% of GDP. The financial report has it higher, and that's because they do things in nominal terms and therefore have more interest payments, but they do not subtract out the implicit tax that comes from the reduction in value of the federal debt with inflation. So I think actually if they were to do that, we would have higher interest payments because we have a higher interest rate. And then we have a higher primary budget deficit, and ultimately we have a higher overall deficit than the financial report of the government. Next slide. Here's looking at particular parts of government spending, healthcare spending. We have it going up to almost a quarter of the economy. Again, one thing that notes is Medicaid grows a lot, and I think this is a contrast to what I understand CBO has, that Medicaid does not grow as much, and that may be worth looking into in terms of accounting for those differences. And then Social Security. We have Social Security higher as a share of GDP than Social Security, and it's largely because our GDP projections are lower. They're more similar to the CBOs, and this is because we have lower economic growth because of a lower population and also less productivity growth for labor. Next slide. The key, relationships and the key results in the model are the healthcare cost and the interest rate. So as we discussed, we have healthcare spending going up. It goes up in a relative price from about 1% to about 1.5%, and this owes to the increasing healthcare demand, labor moving to the less productive healthcare sector. The real government interest rate we have increasing from 1.8 to at its height 2.8. It actually declines a little bit in our model, and that's an interesting feature of the model because demand for labor in all other sector actually eventually declines because of this very rapid increase in spending on healthcare, and then this actually causes a somewhat of a fall in the price of capital. But we have higher numbers than the trustees, and certainly than CBO. So let's do some more comparisons to CBO. Next slide. So let's focus on next slide. Yeah, there we go. So in the next 10 years, we have debt as share of GDP up to 136% of GDP, and the deficit at 7.6%. Whereas CBO has it 112 and 6.1% respectively. And then over 30 years, we have it at 264% of GDP and the deficit at 13.3% compared to CBO's numbers. And what accounts for this? Basically, we have higher primary deficits because we have lower revenue. We do not anticipate, that we do anticipate that brackets will be adjusted over time. That is experience. And we also have higher spending both on healthcare and we do not have the current law controls on government healthcare spending. So those are the main differences which we think are realistic and what the best assumption that can be made, but it is not current law. Next slide. So let's go through all of this, all together. Let's just sort of note that we're looking at healthcare expenditures, deficit, debt, and then the last column is growth and consumption less healthcare per capita. So this is our measure of consumer welfare. And we basically alter the assumptions underlying the various aspects of the model, which may be related to changes in policy. You can look at it both ways. Just probably the most important, just focusing on B, income elasticity. If healthcare spending was less sensitive to income at 0.7, which would be very low, it's not in the U.S. historical experience, but it is possible. We get a substantial decline in healthcare spending. It's not as immediate for the budget, but it is actually very effective in terms of consumer welfare. And then we can make these other changes. Healthcare productivity improves, et cetera, et cetera. If we combine them all in what we call a reform package, H, we do see a substantial improvement in welfare, as well as a lowering of healthcare spending quite substantially, less impact on the deficit and debt, but there is some impact. But clearly more needs to be done in order to get a sustainable trajectory for debt and deficit, which basically I would define as pretty much where we are now. In other words, not to allow debt to increase much beyond the 100% that it is currently, and that to bring down the deficit as a share of GDP. So let's look at more traditional fiscal policy changes. If we start off with our reform package for healthcare, but then we have other changes. B is increasing the share of investment, which is very effective because it brings down the interest rate. And that is very effective in reducing the deficit and debt. And then other changes in terms of further caps on government healthcare spending are very effective as well. But perhaps that is a brute force item, or we could perhaps hope or design something that would result in a major improvement in productivity in the healthcare sector, perhaps through the use of more effective use of capital in the healthcare sector. And then more traditional fiscal policy, cutting government spending, raising taxes, and reforming Social Security, which we model as half in benefit cuts and half in tax increases. So if you add all this up, which admittedly is enormously ambitious, but it's unfortunately really the realistic way to solve the problem, you do get finally a leveling off of healthcare spending, a wonderful improvement in consumer welfare, reducing the deficit to less than economic growth, and debt as a share of GDP is finally stabilized at about 110% of GDP. So that's what the model can be used for. We think it has strengths above official projections in terms of its endogenous interactions among these very important factors. Unfortunately, it does produce more sobering results, which means it's less sustainable than even the official models. But it does indicate sort of where the policy needs to focus. Healthcare in particular needs higher effective capital and labor. But overall, we think we can't avoid these major changes. And that's because demographics does influence everything. So there actually, in terms of the bottom line of all this, there actually isn't that much uncertainty because the demographics are not that uncertain. Thank you.
Thank you so much, Mark. That was a great presentation, an excellent summary of your paper. I'm going to now introduce our other panelists. They're each going to talk for about 15 minutes. And at 15 minutes and 1 second, I'm going to use my mute button to move on to the next panelist. First, we have Steve Goss, who's the Chief Actuary of the Social Security Administration. After him, we have Paul Spitanek, who's the Chief Actuary for the Center for Medicare and Medicaid Services. Then Molly Dahl, who's the Senior Advisor at the Congressional Budget Office. And finally, Felix Reichling, who's a Senior Economist at the Penn Wharton Budget Model. So we'll begin with Steve. And as a reminder, if you have questions, email them to john.mantis@aei.org. Steve, go ahead.
Thank you very much, Mark. And thanks, John, for putting up the slides. First, just want to say thank you very much for the invite to come and join. This brings back fond memories of a little over 10 years, I believe it is, joining Ken Smetters at the Capitol Visitor Center when the Penn Wharton budget model was being introduced. So welcome to the club, Mark, John, and Gabo on your model coming out. More models is not a bad thing. It gives more perspectives. A couple of key points that I just want to sort of mention here is, first of all, rather than going through all of the detail of the models that we have for the trustees, we develop our population, economy projections, and everything to do with Social Security. I'm going to talk a little bit more about some principles. And one, of course, is that what are we all doing these projections for? It's to inform policymakers and the public, but principally policymakers who are going to have to be making decisions about making some of the changes that Mark Warshawsky was talking about. One of the other things that I really want to mention is that regardless of what model or models we all pick, I think we all are well aware and should really emphasize that the real differences are inevitably in what assumptions we make for populating our models about how they go forward. So on the next slide, please. just a couple of sort of little fun facts. One of the things we oftentimes say is there are no bad numbers. What really matters is being entirely clear about what each number represents. And this really is the communication aspect that is so critical, indicating what exactly it is that is being assumed and utilized in the model you're dealing with. The other really important thing is that projections done by using a ruler on past trends are really not such a great idea. What's really critical is understanding the conditions that have resulted in the experience that we've seen in the past, and then imagining what the changes in those conditions will be for the future. And a lot of that really is speculation. The future is difficult to project. So a model itself, by the way, is also an assumption, the way in which you populate and formulate your model. So next slide, please. So projections are inevitably done on some kind of a baseline. And in fact, the first part of any projection is, of course, your baseline. Projections, we oftentimes refer to them as being under current law, baseline to inform on the implications of if we retain current law, but also to indicate the need and timing of any changes that might be needed in order to alter this path. So what are the laws that we're assuming will not change? For the trustees reports, the Social Security Act, obviously. Other laws may be assumed to change by something we refer to as constructive obligation. That is, if something has oftentimes been changed or regularly been changed in the past in terms of law out of need, then it might be reasonable to assume it. We tend not to do that for Social Security Act itself, because that is the baseline that we're making projections from. For budget assumptions, would that be all laws are held exactly constant? Maybe yes, maybe no. There are lots of questions about how to handle, for instance, personal income tax rates. Will we assume that we will have no change in marginal tax brackets other than CPI, change CPI indexing? Always a question. And again, this is one of the things that's critical to really indicate in whatever projections are being put forth, what exactly the assumptions are. So next slide, please. So just want to give an example of how models can actually be adapted to what the nature of the world is. For example, way back before 1972, which was the time at which automatic adjustments came into play for Social Security, there were not automatic adjustments. Things like benefit levels and the maximum taxable level were all just done on an ad hoc basis. So Bob Myers, chief actuary way back when, and actually much involved in the process even before 1935, these models go way back, had decided that because we did not have automatic adjustments, he did not want to assume explicitly that earnings and benefits would be rising over time, because that was not in the law. So he did something rather clever. He said, let's use what we called an average cost model, which actually just in effect assumed that average earnings and prices would not be increasing over time. So if you go with what was a then straight current law, no increase in benefit levels or the taxable maximum, then you would give results that would, relatively speaking, be in consonance with assume that there would be changes in the future. Now, currently, we assume the one thing that is really different from straight current law for the Social Security projections is that income tax brackets will be modified as they have historically over historical periods on an ad hoc basis to avoid ultimate bracket creep or compression, you might say, of the tax brackets, putting eventually everybody all in the top bracket. This by way of making sure we have a more realistic approach, and this by way of sort of the constructive obligation concept. So if we flip to the next slide, please. So the next slide, just wanted to show a little illustration here, something along the lines of what Mark Warshawsky was showing about why assumptions really matter so very, very much. And you see on the left panel here on the solid black line, this is projection of the publicly held debt as percentage of GDP by the administration back in the fiscal year 24 president's budget baseline. And on the right side, you can see what CBO was projecting back at the February 2023. And of course, all these things get modified over time. And you can see the share of GDP that publicly held debt through about 2050 or so is very, very different under these projections. And of course, that's basically because of different assumptions. The one thing I would like to point out then, again, by way of this idea of full disclosure of what exactly is assumed, the black line is what is shown for us for the projection that held by the public. We show in blue and in red if in fact we assume truly current law for Social Security and Medicare. And remember, current law expenditures are constrained by what is available in the trust funds. If the trust funds do not have enough money to pay the full scheduled benefits at a time, they don't. So under current law, that's what the red line really shows. So how much debt relative to GDP would occur under actual current law. There is a budget scoring convention many are familiar with, and we should all disclose when we look at the solid black lines, that assumes that there will be a change in law, providing these trust funds with all the money they need to pay full scheduled benefits, even though the current law does not permit that. So it's really not a pure current law projection, and we should just be very, very clear on that. And the reason this is important is because historically for Social Security, when there has been a shortfall, it has not been handled by just bringing in general fund money. It's been handled by either increasing taxes or altering benefit levels. So the black line really we should definitely be clear on that's a change in law, which has no precedent. And the red line is something I would suggest we should probably look more at. So the next slide, please. Keeping in mind the time, we see for Social Security long-range projections, we have everything available up on our website about the nature of our model and our results. We do careful modeling of population first and foremost, as Mark Warshawsky indicated, mortality by age, sex, and cause, something that has not been typically utilized in many other areas, but cause of death has modified very dramatically over time. It's incredibly important to look at that and not just look at mortality rates as a whole. Fertility rates by cohort, employment, et cetera, et cetera. And employment, I would just mention, and Mark alluded to this, but employment has been increasing for higher ages, as we would expect, with increasing life expectancy and the changing age distribution of the population. But again, assumptions for the long-term future are necessary, and they are absolutely the main drivers for everything we're seeing. So next slide, please. So how accurate have the trustees' projections been? Now, we do have a long track record. Bob Myers and others are making projections back before 1935. One of the key points we like to look at oftentimes is back at the time of the 1983 amendments, the last major amendments for Social Securities. And here's the mea culpa. Back at that time, we were projecting that the trust fund reserve depletion, by the way, we emphasize reserve depletion because when we say an exhausted trust fund or insolvency, the general public thinks it's going to go to no benefits paid. And that is not the message I think that any of us should be or want to be portraying. So the trustees over a decade ago went to saying trust fund reserve depletion, it's like the savings account. Please, everybody, let's go with that terminology for this program. Insolvency or exhausted trust fund really do not convey what is appropriate. But so instead of the mid-2050s, we were projecting back in 1983 amendments, we're now seeing over the last 12 trustees reports, and even earlier than that, it's more like the mid-2030s we're projecting. So what happened? Well, we fully anticipated birth rates and incredibly accurate mortality projections back at that time, and the population, as Mark Warshawsky indicated, has been really relatively stable compared to our projections. Over 80% of the worsening of our projections since the time of 83 was due to unanticipated economic events. So I want to just hit a couple of those in the next couple of slides. One of the main ones really is what has happened in terms of earnings dispersion in the economy. Here you can see even though our taxable maximum has been since 1982, 1983 increased automatically every year by the growth in the average wage in the economy, nonetheless, the taxable maximum has fallen short of maintaining the 90% of covered earnings to be subject to the tax. In fact, between 1983 and the year 2000, it dropped from 90 down to 82.5%. Why? Well, the top 6% of earners, which are actually those that have earnings above our taxable maximum, both in 1990 and now, their real earnings growth over the 17-year period from 83 to 2000 was 62%, where the bottom 94% had real earnings growth of only 17%. Now that's remarkable, and that is really what caused this drop in the percent of the covered earnings that are taxable. But the other really interesting and good thing, I guess, is that we see that we see that it's really been quite stable since 2000. Recessions cause distortions, obviously, but we've been stable at about the 82.5%. We're projecting that to continue. So we had over 20 years experience of a relative stability in this, but it was a big hit, what we took since 83, and this is a major factor. So the other factor on the next slide that we can see, and by the way, you can see here the solid blue line is showing the cost as percent of payroll that we had in the 83 trustees report. The red solid line is what we're showing currently for the 23 trustees report. Now the little dashed blue line is if we adjust those 83 projections, simply reflecting what happened to the share of earnings that are subject to payroll taxes. And you can see that explains most of the difference between what we had back in 83 projections and 2023. There is a bump in the historical period here due to the 2007 and 9 recession, where the cost as a percentage of payroll went up quite a bit above even that. And that was a significant takeaway from the expected accumulations, and also contributes a lot to the fact that our trust fund reserve depletion date is now showing up as 20 years earlier. So the unexpected, very deep and very slow recovering recession of 2007 and 9 was a big hit, but also the drop by about 8% of the expected revenue as a share of earnings was the other big factor. So the next slide, please. So uncertainty. We have a lot of uncertainty about where we're going in the future. Future birth rates, disability prevalence, demand for employment, labor productivity, et cetera, are all really unclear. And again, these are factors that are assumptions made in each one of the models that we're talking about today. One thing that we have to really keep in mind is that we are not a closed economy. International factors really matter. In addition, climate, behavioral responses, et cetera, et cetera. Just a few examples. Do increased taxes really depress GDP? If, as in the case of Social Security, we were to increase taxes in order to allow a greater share of scheduled benefits to actually be paid. So with more people with a high marginal propensity to consume, having more money to actually consume and therefore have more demand, would the somewhat higher taxes really make a big difference? 1 minute, I see a Mark, thanks. So there, other changes in law, like providing general revenue to cover OSDI shortfalls, are really something that are not included in our projections. And on the next slide, I think it is a thank you, and I think I will fall within the 1 minute margin, Mark. And again, thank you very much to AEI and all of you for the invite to join today. Look forward to the further discussions.
And thank you, Steve. You did an excellent job keeping almost exactly on time. Paul, do you want to go ahead?
Happy to. So again, thank you, AEI, for putting this on. You could put up my slides when you have a moment, but wanted to kind of start by just talking about, like, doing 75-year projections are hard. They are uncertain. And when we're talking about doing these sorts of things, and you go to the next slide, I'll talk, this is the walkthrough of what I'm going to be talking about. I'm going to end my comments on the MPW model are my quibble with some of those, with some of the elements that are being presented in the model that Mark walked through. But what I want to start with is that having an integrated view of putting together these factors in a way that where they're recognizing that they're dependent is certainly an improvement, and is certainly something that is worthy of the time today and additional work down the line. These things are hard. There are so many relationships and dependencies that ought to be considered. I said 75-year projections are hard. At this point, I don't know if my staff and I are going to be working in 9 days. So talking about 75-year projections is something that is well beyond the comfort level of any modeler here. I'm going to walk through very quickly some of the work that we've done at CMS in terms of doing our longer run projections. And then ultimately, like I said, I'll have 3 slides of quibble. And I look forward to kind of hearing and seeing the work that Mark and his team do to kind of continue this work forward and make some improvements. But if we can move on to the next slide. So where we are on the work that we've done in the Office of the Actuary at CMS. We started, 20 plus years ago, off of a period in which, the 20 years prior, we had health spending growing at levels of GDP plus 2 or 2.5% consistently. Where health spending was growing much faster, and recognized obviously that cannot continue indefinitely, and certainly when you're looking in the very long run, you need to have some constraints. And so this constraint of GDP plus 1 was adopted. The model transitioned to say, well, we need to kind of have a little more rigor towards, recognizing that, spending is growing even faster in the earlier periods and it'll grow slower in the later periods. And so this computable general equilibrium model effectively just drew a curve that would accommodate a GDP plus 1 overall approach over the long run, but recognize some of those individual starting point factors. Where we've emerged through, and some really good research and work supporting this, is this current factors contributing to growth model. This model is now being largely used by CBO. Elements of this are in the work that Mark described, but basically it just looks at the preferences. It's a preference model, looks at elasticities over time. I will show some a little more details through there, and while we recognize that there is a slowdown occurring in health spending over time, we are not specific at all in terms of identifying exactly what is causing that slowdown to occur. For those that are interested, and certainly would recommend looking into some of the detail, to really, that work builds off of some of the work that on the factors contributing to growth analysis that has been longstanding and worked through in our office. You go to the next slide. So here is the model, pretty straightforwardly. Look at the income growth, look at the health spending, the health price piece of it. There's an insurance piece that's assumed to not change over time. And so you can see these income elasticities do decline over time. The relative medical price elasticity is pretty consistent over time. And we'll talk a little bit more about the health prices and total factor productivity in a moment. But go to the next slide. You can see that we are using this model starting 25 years out. So we have done the analysis to kind of draw the curve, and we try to maintain this curve as much as possible. I think one of the features, and this isn't perhaps an extension of a quibble that I'll have with the model that Mark walked through, is that one of the features I would look for in a long-range model is that updates to the model, underlying data, modest changes to assumptions, don't materially change the ending path. And that's why we kind of have fitted this over a very long period of time. We update it every so often and those updates generally don't move the analysis all that much. Let's move on. And so this is actually mostly Mark presented part of this. He layered his model on top of this. One thing I wanted to add to this, and so yes, the Medicare alternative versus the current law constraints. There are some elements of current law that the trustees and I believe will be challenging to fully implement in the future. So that's the difference between the red and the yellow in the projection. But one thing that I wanted to point out is that what we've seen over the last 10 plus years is we've seen that massive shift in demographics. The aging of the baby boom, and this will be even more clear. Actually, let's jump to the next slide, please. Where you can see over this last decade or so, this is the long-range Medicare pieces, and you can see this as a share of GDP. We've had the massive shift in demographics here, and we've had notable increases in the health spending, but that trajectory has clearly leveled off, and it's certainly on a per capita basis, it's much less, much flatter than what that recent history has presented, and so completely agree with some of the points that have been made. That's largely demographic driven is where lots of these long range models end up. But to the extent that the last decade is some indication, we've had the massive increase in the Medicare population. We have not had the massive increase in Medicare spending as a share of GDP, and partly that's there's price pieces, and I'll show a little bit about that in a moment. Let's jump to the next slide, please. So there's lots of similarities between the two methods, between the two models. The three that I'm going to spend a little bit of time on is that there's some what I'll call unusual results in the latter half of the projection period in the model that Mark walked through. There is some higher assumptions on relative health prices, and the labor productivity is notably different. So let's jump to the next slide. Starting with the box on the top, that's actually the main point of this slide. I'll jump to the bottom in a little bit, but you could see that the share of NHE as a share of GDP between the CMS and the model that Mark walked through is actually very comparable over the next 30 years or so. There's not much of a divergence there. The 24.6 versus the 26.2. Where you really see that key divergence is in that latter half of the model. Where the CMS is at 32, the Mark. I'm not sure what the right thing to call it. I'm going to keep calling it the MPW or the Mark model. It diverges way up to 41.6, and so we'll kind of try to unpack that in a little bit. But a key part of that is clearly Medicare, and you can see that Medicare is projected to growth even under the alternative assumptions where the current price updates aren't fully adhered to in the future. Is projected to increase up to the 8.2%. In the MPW model, it's projected to increase by 11.5%. One of the reasons why we thought that might be the case, and this actually isn't the largest piece of the difference, but one that I wanted to emphasize here, is that we have reflected, or recently, this was in the 2020 trustees report, we reflected the demographic, for purposes of calculating the demographic factors, we've incorporated prior to 2020 trustees report, the demographics were calculated based on an age and sex basis. They're now calculated on an age, sex, and time to death basis. Now, we released that in the 2020 report, which came out in April 2020. Needless to say, lots of things that were happening in the health space in April 2020 that were not specific to a emerging and scary pandemic did not get a lot of attention. So I'm going to provide a little bit of attention here to show that the reflection of time to death is a pretty key one in terms of looking at what long-range health spending effects will be in the face of changing demographics. As mortality improves, we all know that health spending generally increases, in the year that someone dies, and it also increases, in those years leading up to their death. And to the extent that deaths are occurring later in life, those are effectively providing some downward pressure at least on the demographic side of health spending. So you can see that the difference here in the long run is worth about 5 percentage points. And there is a link on this slide that will actually present a little more information if you are interested, and certainly would encourage people to spend a little time looking at that time to death analysis and the demographic implications. Moving to this next slide, this is just an assumption where we just have a very different view. I know Mark indicated that this isn't effectively an output into his in that modeling, but just looking at the history here, and so we have the producer price index information charted here, but we kind of don't view that as all that useful or relevant for modeling long range relative price changes. And if you look at just in this post PPI world, we've had these prices have been increasing below 1% each and every year, and in the very recent past, in the last almost decade or so, relative health prices have been negative, and so the long run assumptions that are used in the trustees report are the 0.75%. The model that Mark walked through, the average turns out to be 1.5%, and so that actually does tend to be a key driver, and does at least provide a fair amount of the differences between some of the modeling we're seeing. The last slide I have talks about the labor productivity. The model that Mark walked through assumes labor productivity at about 0.4% per year. We have it at closer to 1%. We actually have 0.4% as the total factor productivity in the health sector. So there are that is a pretty sizable difference there. You can see the effects of this when you look at some of the projections of health share of employment. You can see that the relationship between the history in health share employment and national health expenditures is pretty consistent over time. We've also added on that we've done some additional work. So what's measured in the economy, that the 5, 3, 7, 8, 10, 1, that is just direct health workers, so those that are in hospitals, those are in physician offices, and the like. If you add in those that are also contributing to the health space, so insurance, pharmacies, production of pharmaceuticals and the like, you do get a fairly different labor share there. But then as you look at those projections, mostly due to the changes in the projection of GDP. So the Mark model, the MPW model, 42%, whereas we have 32%. But that's actually contributing to even a greater share in health employment differences. So that 28% versus the 19%. So there is actually, so like I said, 75-year projections are hard. Quibble over some of the smaller assumptions, but recognizing that having a comprehensive view of how various sectors of the economy are interrelated is a valuable addition to the discussion, and certainly I look forward to work as it progresses on this model.
Thank you so much, Paul. Molly, you want to go ahead?
Yes, thank you. I'll echo, while somebody's pulling up my slides, I'll echo statements of others thanking AI for putting on this event and inviting us all and hosting this interesting discussion. Great. I didn't know if I couldn't see my slides or they weren't up yet. Perfect. So thank you for putting this on. This is fantastic. And we could just go on to the next slide, please. So I want to also echo a statement that I believe both Paul and Steve raised and Mark, which is long-term projections, whether CBO does some extended baseline projections that go out for 30 years. For the Social Security program, we do projections that go out for 75 years. Long-term projections like this are inherently uncertain, very much driven by views and beliefs about how the economy will evolve and how programs will evolve. And I would also note here, CBO does its projections under the assumption that current laws generally remain unchanged. And these projections do show the estimated effects of demographic trends, economic development, healthcare costs, all rolled in, and their effects on federal spending, revenues, deficits, and debt and the economy over the next 30 years. And I also want to say I'm going to talk a little bit about our demographic and economic projections in a few moments. And those demographic and economic projections underlie all of the budgetary projections that the agency does. So we can go ahead and scroll forward. So starting a little bit with the top line, or some of the top line projections that we do in the long-term budget outlook, which is one of our reports. This most recent one came out in June of this year. So we have large and sustained primary deficits extending through the 30-year window. Those large and sustained primary deficits combined with rising interest rates relative to current levels or relative to recent history are leading to increases in net interest outlays, and then of course related increases in the total deficit or larger total deficits over time. And I think, as has also been said here, I think there's a broad agreement that putting aside, regardless of the details, it's a challenging or a daunting fiscal situation. So we can roll into the next slide. Thank you. And so we are projecting, when you think about how those deficits build over time and the current level of debt, we're projecting federal debt held by the public to be about 180% of debt to GDP, to be about 180% in 2053. And so I also want to note, we have an alternative set of, so these are all the results I'm showing here are all our current law projections. We have an alternative set of scenarios that we look at in that we issued in a separate report this year that came out in July of this year, where we look at sensitivity analyses. What would happen if to debt to GDP if total factor productivity increased faster or slower than we're projecting, if interest rates were lower or higher than we're projecting, if historical spending or revenues were more in line with historical experience, recent historical experience than CBO is currently projecting, and also looking at what the effects would be of what we call a payable benefits scenario for the Social Security system. So under our current law projections, or under our projections, we're instructed to consider Social Security as Social Security scheduled benefits scenario. That is, that Social Security benefits are paid out as they are scheduled under current law. But we do look at an alternative scenario in which Social Security benefits are constrained to the amount of available, basically the revenues coming into the system after trust fund exhaustion. And I want to note, we can go on to the next slide, but I want to note as we're doing that, one of the things that we do in our alternative scenarios report that I mentioned is in thinking about debt to GDP and the effects of increasing levels of debt over time on the economy, we didn't report estimates in which, or projections in which, debt to GDP exceeded 250% of the size of, or in which debt exceeded 250% of the size of the economy, in part because of the considerable uncertainty around what the effects of such high debt would be on the economy. And it's not that necessarily we're not identifying a tipping point. It's just an issue of, it's unclear whether or when such high debt would have and what effects that would have on the economy. And so given the massive uncertainty in those projections, we actually just, we don't show those. So CBO's, oh, sorry, scroll back, sorry, thank you. So I want to talk a little bit, a lot of the discussion here has been focused on the economics. So I want to talk a little bit about our approach to economic forecasting. So our approach involves projections of both potential output in a solo type growth model and actual output in a standard macroeconometric model. And our potential output is mainly based on estimates of potential labor force, flow of services from the capital stock, and potential total factor productivity in the non-farm business sector. So now next slide, please. Thank you. So in CBO's projections, real potential GDP grows more slowly throughout the 2023 to 2053 period, driven both by slower growth in potential labor force productivity and slower growth in the potential labor force. Next slide. So again, one of the questions that's come up in discussion today has been one of what are the effects of the healthcare sector going forward, or what might the effects of the healthcare sector on the economy change going forward relative to what we've seen or what we've experienced in history. And so CBO's current view is that we have no reason to expect the healthcare sector to evolve significantly differently than it has been evolving historically. And Steve, I believe, had mentioned climate as one of the issues that we all need to be very clear about what we're thinking about the effects of climate on the economy and so forth and so on. So I did actually want to talk a little bit about CBO's views on the effects of climate change on the economy, partly to say, when we think that the effect of something, in this case, climate change, the effect of something in the future will be different than historical experience would indicate. We think very, very hard about that. We bring that into our projections. We write about it extensively, and climate change is a recent example of a way in which we've done this work. So in at least two ways, climate change is going to affect CBO's projections of, or does affect CBO's projections of economic growth in future decades. So first, sorry, can you back up? Sorry, thanks. First, climate change has affected recent productivity trends. And some of our projections are based in part on those recent trends, and so implicitly account for a portion of the future effects of climate change already, or even without this additional delta that I'm going to discuss. And then the agency explicitly estimates an additional impact on the growth of TFP from future changes in the climate. And so in all, we have climate change reducing CBO's projection of GDP in 2053 by 1%. So you can scroll forward. And so we first implemented this in our projections of GDP in 2021. We talked about it extensively in the 2021 long-term budget outlook. And we also have written about it, most notably in a working paper by Evan Hernstadt and Terry Dinan that was released in 2020. Let's go forward, please. Thank you. And so this is not a significant focus of my discussion today, but rather just to say, or to indicate that when CBO digs into these things, we think when CBO identifies issues that warrant additional research and thought, we dig into it, and it's a very detailed analysis and discussion, and relies on help from a lot of experts and consultation with many, many folks. So I'm going to turn back to budgetary outcomes. So if we could go to the next slide. Thank you. So this is a very familiar figure for us at CBO, in which we have projections of outlays and revenues, and projections of average outlays or projections of outlays in general, are growing faster than revenues in our projection period. Next slide. So when we break these outlays out by category, as already mentioned, net interest spending is a significant driver of the increase in outlays, as we've been discussing, major federal spending on major healthcare programs. So next slide, please. And in particular, underneath the hood on the major healthcare programs, Medicare is a significant driver. So we have Medicare spending is accounting for more than 4/5 of the increase in spending on major healthcare programs over the next 30 years in our projections. Next slide. Thank you. So I want to talk a little bit about how CBO projects its spending on healthcare. So we have a 10-year baseline set of 10-year baseline budget projections, and those projections provide a benchmark for our cost estimates that we produce for the Congress. And those projections are based in part on a detailed modeling of the healthcare system. And then in the second 2 decades, we use a more aggregate and mechanical approach to project spending for the 2 decades that follow. That's very much in line with what Paul was talking about earlier. Next slide. So inside the 10-year window, we start with the most recent data on Medicare spending, and then we build forward from there. So we have projections of the Medicare population, which are again integrated with our projections of the total population, which is the same projections that underlie our Social Security projections and our revenue projections and so forth and so on. We also have projections of price, changes in the composition of the Medicare population, anticipated policy changes, and then growth in Medicare spending that cannot be explained by those factors. Next slide. So in the second and third decades, as I mentioned, we use a slightly more mechanical approach, and we break growth in health outlays down to growth in CBO's beneficiaries cost index, growth in potential nominal GDP per person, and what we call additional cost growth. Next slide. And so CBO's estimates of additional cost growth move linearly from the rates at the end of the 10-year budget period to our estimated rates at the end of the 30-year projection period. And so for healthcare overall, our estimate is that additional cost growth at the end of the 30-year period will be about 0.6%. And so our estimate for Medicare Part D matches that for healthcare overall at 0.6%. And we have lower additional cost growth in the 30th year for both Medicare Part A and Medicare Part B, in part reflecting the spending controls in current law. And again, as I said, this very closely matches in methodology what Paul and his colleagues are doing. And I think, also, their thinking around the estimates of key parameters and such has been incredibly important for us as well. Next slide. And so there's some relevant CBO publications. Again, we endeavor to communicate all of this quite clearly, or as clearly as possible, over the course of time, and have a series of reports that come out largely on an annual basis to do such. And again, as we've noted, I think it's a challenging fiscal situation, and healthcare spending, including that on Medicare, is a significant driver of increases in outlays. In CBO's view, the economy will continue to adjust, as it has historically, to accommodate those changes in the healthcare sector. But as we continue to learn more and observe and gather more data, obviously this is something that we think hard about and will continue to think hard about. So again, I want to say thank you to AEI for the conversation, and I'm looking forward to hearing more.
Thanks so much, Molly. And I want to remind people again that if you have any questions, you can email John Mantus. That's john.mantus@aei.org. And now let's go on to Felix.
Felix, you're on mute.
I'm sorry, I'm still on mute. I was wondering why the slides didn't change. As previous people mentioned, thank you so much for inviting me. This has been a super interesting event. I'm looking forward to some good discussions. Next slide, please. So the main point I wanted to make about the MPW model is that it is still a reduced form model and relies heavily on historical data. And their estimates are not the result of a structural model in which households make decisions and optimize their behavior, which is especially important going forward, because my expectations would be that there are changes in the healthcare sector that are quite dramatic going forward, given how big the impact on the economy is. So I would argue that without a structural model where households make decisions and prices are equilibrium outcomes, analyzing novel policy changes is just bound to be very imprecise. So just relying on historical data could be misleading. Next slide, please. So I'm going to spend most of this time to introduce our Penn Wharton budget model, and then show you some of the policy analyses we've been working on. So this is a broad overview of our model. On the left-hand side, it starts with a micro simulation model that basically generates a lot of demographics that then feeds into a text module, a social security module, and together those provide inputs for our dynamic OLG model. The dynamic OLG model at its core is very standard. It's a large heterogeneous agent stochastic OLG model where households face income shocks over their life cycle, and they choose labor supply, consumption, and saving optimally. And embedded in that model is a comprehensive healthcare model. Next slide, please. So that healthcare model includes households who differ by health state. They differ by their shocks to health and health expenditures over their entire life cycle. Households choose whether to enroll in health insurance and whether to invest in healthcare or forego healthcare altogether. There's a competitive private health insurance market that include employer subsidies and the tax advantage treatment of employer-provided health insurance. We model government-run health insurance programs, the major ones at least, Medicare, Medicaid, and the Affordable Care Act. And we have out-of-pocket spending policies and administrative costs and excess cost growth that differ by insurance program. All right, next slide. So these are the policies I'm going to talk about. Think of them as major health insurance spending reforms. The first one is a no tax benefits policy, where we assume current law continues, but we get rid of the tax deductibility of employer-sponsored health insurance premiums. And for those who are not aware of this, the tax subsidies provided by these tax deductions are actually very large. In 2020, there were about $320 billion, and about 70% of how much the federal government spent on Medicaid. And CBO projects that by 2032, the cost of these subsidies will be over $600 billion, which would be about the same as the federal government will spend on Medicaid. So these are very large subsidies. And another point is these subsidies are highly regressive. So high-income households with high marginal tax rates receive significantly higher subsidies than lower-income households with lower marginal tax rates. And this is basically an assumption that will also apply to the next three policies. The second policy is we expand healthcare or health insurance really to the entire population. So enrollment is mandatory. We assume that the ACA will be discontinued. The third policy is a hybrid policy, kind of like, I mean, these are all in some ways motivated by Medicare for all, by the Medicare for all discussion. But here we assume that, again, enrollment is mandatory, no more ACA. Households will pay the current law Medicare premiums, and the rest will be financed through a payroll tax. And the fourth policy is just a straight out payroll tax finance expansion of health insurance. Next slide, please. So all these policy changes have first order effects on labor supply. The no tax benefits policy is essentially an increase in labor income taxes. And from basic economic theory, we know that that will decrease labor supply, which it does in the model, so that's good. For the hybrid and the payroll tax policies, they have the same decrease in labor supply due to getting rid of the employers, the subsidies. But in addition, they also increase the payroll tax, and more so in the payroll tax policy, which decreases labor supply further. And a third reason why labor supply is lower is that those two policies insure households against income fluctuations. So if somebody's income drops, their contribution to their health plan drops as well, which is the opposite with the premium policy. When somebody's income drops, their premium stays the same. And with mandatory enrollment, they don't have the ability to opt out of becoming insured. So they increase their labor supply and their savings to insure against those possibilities that their income drops and they have to continue paying those premiums. Next slide, please. So output mirrors the effect on labor supply very well, with the exception that it's slightly exaggerated because there's also capital effects that are very similar to the labor supply effects. Under the premium policy, output by 2060 could be as much as 10% higher than under the baseline, whereas under the payroll tax finance policy, it will be more than 20% lower than under the baseline. So just changing the way healthcare is financed can have major impacts on the economy. Next slide, please. And of course, on federal debt. Under the no tax benefits policy, even though the government saves on these tax benefits on employer-provided health insurance, deficit still goes up. And the reason is that we assume that once the tax benefits go away, employers stop providing healthcare. There's really no more reason for them to be in the business of providing healthcare. So households will get the healthcare in the market, and under current law, they will qualify for ACA premium subsidies. So there will be a lot more people qualifying for ACA premium subsidies, which can be substantial. And overall, that will increase debt by roughly 10% by 2060. The other policies lower future debt, for one reason, because there are no more tax subsidies paid by the government and we get rid of the ACA. And the reason why that differs so much across these policies is that because of the labor supply impact. If households work more, income taxes increase and further reduce the debt. Next slide, please. So this is a welfare analysis that properly done can only be properly done in structural models by having well-defined utility functions. Not surprisingly, the no tax benefit sees a large increase in policy. Basically, we take subsidies from high-income people and give them to lower-income people through the ACA premium subsidies. And in addition, as we saw in the debt graph, the federal government spends a lot more on subsidies. So overall, households will be happier. For the other three policies, their welfare effects for the working age households don't differ tremendously, but for those born in 50, 60 years, those on the right-hand side of the figure, the payroll tax really lowers welfare because of the crowding out that happens to capital, which then lowers wages and overall standard of living. Next slide, please. Our model also has something to say about the fraction of people who are uninsured. Obviously, under the premium, hybrid, and payroll policies, everybody has to enroll in health insurance, so that drops to zero, the uninsurance rate. But under the baseline, the black line here, the fraction of households who are uninsured would increase from roughly 11-12% in 2020 to over 30% in 2060. And the reason is that healthcare becomes more and more expensive, and more people much rather self-insure than by insurance policies that they may not need. Also, note here that this increase might be a little more than what you may expect, simply because we have only one insurance policies, and that offers a certain benefits that are similar to those offered in 2020. And they will stay the same over the period, at least in this version of the model. Historically, what we have seen is that insurance premiums went way up, and the benefits that health insurances covered decreased. So they became skimpier, but more expensive. So here we only have the price going up, but the benefits actually stay the same. With a no tax benefits policy, health insurance becomes more expensive because the subsidies go away, which leads to a lot more adverse selection. Basically, high income and healthy households drop out of the insurance market, and that increases the uninsurance rate. Next slide, please. So this is what the model tells us about the fraction of households who forego medical care. In 2020, that is calibrated to what we see in the data, which is about 12% of households who forego medical care due to cost, and that will rise over time with the increase in general healthcare cost. The no tax benefits policy is really not that different in the long run. In early years, it's slightly fewer people forego medical care, but under the premium, hybrid, and payroll tax policies, where health insurance is mandatory and everybody has health insurance, foregone healthcare really drops a lot, but it doesn't go to zero. And the reason is households still have to spend money out of pocket to get care. The reason why the premium policy sees less foregone care is that households have just a lot more savings that they can use to finance those out-of-pocket spending expenditures. Next slide, please. So our model then also has something to say about average health. Under the baseline, thank you. One more minute. Under the baseline, average health worsens, and so the way we measure wealth is from excellent to poor, and excellent has a value of 1, poor health has a value of 5. So an increase in average healthy is really a worsening of health. Under the policies with mandatory insurance, health is a lot better than under the baseline. And that has also effects in the model on household productivity. Next slide, please. Right, so this shows health insurance cost without tax subsidies. And really what I wanted to focus on here is that under the baseline, the cost of health insurance more than doubles over the next 40 years. If we take away the healthcare subsidies, there will be a substantial increase in cost before subsidies. And the reason is adverse selection. A lot of healthy people drop out of the market, making everything else, those who remain paying higher cost. Under the premium policy, where everybody has to be insured, there is no more adverse selection, and premiums would be significantly lower. Next slide, please. So this shows you the health insurance cost with tax subsidies. And here now, the one with no tax benefits has the lowest insurance cost because of the big ACA premium subsidies that are paid, and they are substantial. Yeah, just one more thing. next, because of the tax subsidies that the federal government pays, the baseline rates are now the second lowest, and the premium policy would be higher than both of those. Next slide, please. So just a quick conclusion. I think the MPW model is a step in the right direction, having an integrated model. But I really encourage the authors to go a step further and work developing on a structural model that can maybe better account for policy changes that we have not observed in history. And basically, that's what the policy changes that I just discussed. They're large and very different from what is available in historic data. And models based on historic data will likely miss some important points here. Thank you.
Well, please join me. I know since we're virtual, they won't hear your round of applause, but please join me in thinking about giving a round of applause to all of our panelists for, I think, really excellent presentations and a lot to think through. Again, if you do have questions, please email John Mantus. I'm just going to give the email address one last time, john.mantus@aei.org. Let me start off with a couple, and I hope we can get a good discussion here. But yesterday, the 10-year Treasury yield hit a 15-year high. It closed at about 4.5%. The 3-month is about 5.6%. These are half a point to a point above what CBO was projecting they'd be right now. They're actually relatively consistent with where the trustees think they're going to end up. And they're also well above what I think most of us project the long-term growth rate would be. My question, which I think would especially be for Mark and Molly, and to a lesser extent Felix, is to what extent is this higher than expected interest rate? How would that play into your model, into your projections, and how does it change the risk of potential debt spiral looking forward?
Oh, well, in terms of our model, we do have to, initialize the government interest rate by what the risk premium is, and so to the extent that the initial government interest rate is higher than what it has been historically, and then we think will continue, then that flows directly into everything else in the model, so that the deficit is higher, and it has all the bad effects of an increase in the deficit. So we don't want to be too quick on the trigger in terms of monetary policy doing this or that. Those sometimes are short-term effects, and they get washed out over the long run, 30 years or even beyond that. So you want to be a little cautious, but if there is a significant sea change in terms of views and in the market, let's say, and the other thing that let's say if the real interest rate, let's say on tips, has gone up, which I think it has, that becomes a little more concerning, and something that the model might want to have to include.
Molly or Felix, do you want to react at all?
Sure, I'll jump in. So so a higher than expected interest rate, it flows through quite naturally to higher interest costs, flows through to higher debt, flows through to increased crowd, would flow through to increased crowd out and slower economic growth. Of course, I would also say the U.S. position, and you mentioned risk of a fiscal crisis or a financial a crisis of some ilk. The U.S. financial position is position relative to other international markets is very different in that we have aspects of our economy and how that debt is issued that differ from other countries, and so I wouldn't go much further than that. But this is obviously something that our macroeconomic analysis division, of which Felix used to be part, will be looking at very closely, obviously, as we're already gearing up for next year's forecast.
And I just want to say, in the policy analysis that we performed here, the higher interest rate, as Molly said, leads to higher debt, and higher debt as I showed under those three policies, the last three policies, and debt will be lower in the model. With higher debt under the baseline, those effects would be even larger because there's fewer deficits that add to debt, and so you have even bigger effects on debt and on output than under the baseline that we are running.
Mark, could I just add that just over about 10 years ago, CBO, OMB, and the trustees were all assuming real interest rates on treasuries would be at 3% or higher. Experience of the last 10 years has caused a lot of thinking that it's going to be lower because of the Fed and maybe lower forever. But just remember, just over 10 years ago, everybody was assuming 3% real, and definitely. Could we get back there? Plausible.
I want to ask another.
Yeah.
I want to ask another question, a little bit more on the methodology, but I want to bring in a few of you because Mark, I think one of the kind of key assumptions in your model and your healthcare assumptions is that essentially labor and capital are not substitutes at all in the healthcare sector, and there's good historical reason to think that was true, but there may be reason to think it won't be true in the future. For example, I don't think any of us could envision AI, doing a nursing job, but radiology, imaging, diagnosis, certainly I could imagine AI being better than a human and certainly be able to substitute for some of a human on that. So I kind of want to press you a little bit about whether you think that assumption holds forward. And then I also want to ask the other folks that are modeling healthcare, whether they sort of implicitly have similar or different assumptions.
Yeah, thanks for the question. And it certainly is a possibility, but I think one thing, the modeling is done to inform policy, and really key point, and this is actually one of my colleagues here at AEI, Jim Capretta, has made this point, I think, very eloquently, is that the structure of payment from the government, which it now pays for more than half of healthcare, is very important in terms of the incentives for the introduction of those type of technologies, and so that capital would be more efficiently used in healthcare and would increase total factor productivity in the healthcare sector. But I don't think we see that. I think it's inconsistent. So basically, what are the incentives for a hospital, doctor's offices to introduce these technologies given current payment structures? And I don't think they're there. Obviously they should be there, but that's a policy change that needs to be included to change this trajectory. So actually, in that sense, I actually agree with Felix. Obviously, our model can't model everything that he's done. It doesn't have that level of detail, but I think it is in fact the case that these policies could have an impact going forward that we don't see in current policy and in current trends.
So I'll just add a couple of points to the general notion. So healthcare currently is very labor intensive, and we expect it will continue to be heavily labor intensive into the future. And the other observable fact is that in the past, and perhaps for all of history, technological advancements, improvements in technology have been cost increasing. And there has not been a lot of evidence of cost reducing technologies in the health space. Now, does that mean it'll be forever into the future? That one I think is less certain, but along with, as Mark indicated, current incentives do not necessarily suggest that there'll be a dramatic shift in those two key factors.
So this is an audience question I want to pull in, but
sorry, Mark. I just wanted to, could I just add quickly? One thing that I mean, obviously we, as I'm sure everyone here are thinking about AI and watching it very closely. But it's also the effects of such things inside the healthcare sector are one question. Then there's another question of whether there could be effects outside the healthcare sector that free up more labor. relative to what we're seeing currently that allows more labor to flow into the healthcare sector. I just wanted to raise that.
And Mark, if I could just add that one interesting observation, Mark Warshawsky mentioned that the government finances a lot of healthcare, but doesn't provide it. In other advanced economies, I think everybody's aware that the share of GDP that goes to healthcare is dramatically less than in the US, and yet life expectancies are higher. So I don't know, this is something that any of the people projecting health have taken into account, the possibility of shifting the nature of the way healthcare is provided in the future, and who is providing it as well as paying for it. That would be obviously a big change from current law.
Okay, well, I want to use that to ask, sorry, go ahead, Felix.
So we have done some analysis of that, which is, with the model that we have, it's relatively easy to make those assumptions, and obviously then welfare and everything, what I just showed looks much better than sticking with the system that we have right now.
So I think Mark made, and this kind of jumps off this, made a very compelling case that we should look at what's going on the supply side in the rest of the economy and feed it into healthcare, whether it's demographics, whether it's capital, whether it's labor. Should we also be doing the reverse, looking at what's happening in healthcare and seeing how that feeds into demographics, for example?
That question has been posed to me. I mean, implicitly in the model, it's there, but it is very implicit. So, I mean, we do have obviously the demographic projections, and that includes whatever effect historically or going forward, the spending on healthcare does in terms of increasing longevity, also in terms of productivity, the effect that has. That historically, and then to the extent that it continues, but it is implicit. It is not explicit, and it would be a reasonable thing to add in the future. I think there's and based on my reading of the literature is that there's a little less clarity on that point, and such as to include it in a model. It's a little more. A little more on the edges,
and that effect is explicitly modeled in what we do, because people's mortality depends on their health and their age in our model. So if under the policy experiments people get healthier over time, there will actually be an increase in the population size and labor force because of that, and that is an effect that is already taken into consideration in our model.
If I might add to that point, as Paul mentioned earlier, we have a heavy emphasis in this country on end of life healthcare. Part of the reason a lot of the other advanced economies probably are doing better in life expectancy, with even spending less on health, as they have a greater share of their health expenditures for people at younger ages to maintain health, thereby extending life expectancy by more than if we just get health expenditures of people who are already terminal. So that is a possibility for change in the future.
I want to turn to an audience question, but also build on it. The audience asked, why do CBO and the Medicare trustees differ so much on the hospital insurance insolvency date? I believe the trustees are at 2031 and CBO's at 2035. I'm sorry, Steve, the trust fund depletion date. I'm not sure, Mark, where you are in your model, or Felix, where you are, but maybe Paul and Molly, do you want to, either of you looked at this and can discuss some of your differences?
I was going to let you go first, Paul.
Well, thanks. No, we don't have specific analyses that have done a compare and contrast around those differences. I know we are consistent, more consistent in some of the longer run expectations, but in the shorter run, we have built in, notably, over the last several years, including through the pandemic, health spending has just been a lot lower. In particular, Medicare spending has been a lot lower than what was expected prior to the pandemic, or previously. And so the question of what does it look like to either return to a path of normal health spending, or what the trajectory was expected before, or are we in a different paradigm in terms of what the level of spending will be? That said, one of the factors that we have incorporated into the Medicare spending is that the morbidity effects of the pandemic on the Medicare population. COVID, attacked the older and sicker of Medicare, of the population at whole, but the Medicare population in particular. So those individuals were expected or projected to be dying within the next several years anyway. And so, if part of the reason we've been able to explain for some of the lower spending is that the surviving population, those that did not perish in response to COVID, is somewhat healthier than the average population would have been expected to be. And so we have that effect wearing away over the next several years. But again, we don't have a specific comparison of, attributing the differences between the Medicare projections and the CBO projections.
Mark, if I might mention, I think it's actually reversed, the trustees versus CBO on the reserve depletion date for Social Security. I think that's largely because of optimism about the economy. The trustees have reserve depletion earlier than CBO.
They're earlier in Medicare. Is that what you're saying?
Well, no, I'm sorry, for Social Security trust fund reserve depletion. Where Medicare, I believe you indicated that reserve depletion is even later under CBO, which has to be
Correct.
because of what Paul is suggesting about healthcare utilization.
Well, I would, we have not done a direct analysis of why we differ from the Medicare trustees on the HIA trust fund exhaustion date. But we at CBO have also taken on board our views on changes in the effects of COVID on the Medicare population and mortality and morbidity, as Paul was saying. And so it's also, some of it is, I'm sure there are underlying modeling assumptions on which we differ, and I have not, obviously haven't done, as I just said, a detailed analysis, but that the HI trust fund exhaustion date is not too far into the future, and probably in the early 2030s, I think is again, going back to the uncertainty around these estimates and the importance of the underlying assumptions. What the actual drivers are, I'm not quite sure, but I think from a policy standpoint, the HI trust fund is nearing, or is expected to be exhausted in the early 2030s in either one of our models, and there's a lot of consistency in that.
Yeah, and one thing I'll point out to the questioner is, unlike Social Security, the Medicare hospital insurance has a relatively small deficit and a relatively small trust fund. So that means that even small differences in revenue or spending assumptions can mean a multi-year difference in the depletion date. Whereas for Social Security, you need pretty big differences to get more than a year or so apart. I want to ask if any of the panelists have a question for Mark, especially since he's got this very long paper that I know you all read right before we got on this morning. Okay, sorry, Steve. I thought that you emailed me that you had one, but I'll ask another, which is about what the effects of the deficit. Obviously, that's what I do all day. So I'm going to ask you all how you think about the effects of the deficit feeding into economic growth. Mark, you talked a little bit about your crowd out assumptions, which seem relatively quaint compared to CBOs, as I understand. And on the trustee side, as I understand it from your presentation, Steve, you really sort of make no out of model assumptions on the debt based on the Bob Myers inspired approach. But if Mark or anybody else wants to chat a little bit about that, would love to hear.
This is lifting the curtain a little bit on modeling, and I'm sure my fellow panelists will find this of interest. This issue of the effect of the deficit on interest rates, on investment, on capital accumulation is really very key, in the long run. The model indeed is very sensitive to this assumption. And if you were to increase it from what we have, which is, is on the lower end of the literature, you get much worse results. And even to the extent of, instability in the model, which, may reflect a reality of, call that a crisis, or it may just be, a modeling issue that, the instability is there. And I think Molly alluded to it when she said, they put this cap on 250%. I don't know that happens in their model, but maybe something similar does happen. And so, it's a judgment, and it's certainly an issue, but it does highlight. I mean, in the nature of what Steve had adjured us, all of us, to be, transparent. It is a key assumption, and it is a very sensitive point in terms of modeling, but I also think in reality. The investment process, the accumulation of capital is so incredibly important to welfare in terms of the government budget, in terms of everything.
If I could just add, haven't been referenced here. I'm not going to say how long ago, but I'm talking with the CBO director quite some years ago, not the current one, and asked why, with the very large increases in debt to GDP, were they not having interest rates rise a lot more than they were? And they said, well, our models would suggest that, but inherently, we really think that something is going to be done that will avert such increases. And therefore, they were not sort of building constructively in the kind of, what modeling would normally take us to in terms of interest rates. That said, of course, we are, I think, for the trustees at a 2.3% real interest rate, getting there rather quickly, which, Mark, until your model, I think we were at the height of others. Now, I think you're exceeding us. So I would say that we are arguably within the realm of current thinking at a relatively high real interest rate, which you could say is consistent with increasing debt.
I can't speak to Steve's previous conversation, but I will say that the increases in deficit and debt do lead to increases in interest rates because of crowd out in our modeling. And so anyway, I just wanted to say that.
Clearly the case in current CBO modeling. Yeah.
I do remember Paul Ryan used to describe the CBO model as blowing up when it hit past, I don't remember if 250 was the old cap or if it was 300. And some of the folks at CBO didn't like that kind of rhetoric, so he stopped using it. But that was a decade ago. Here's my last question.
Never mind, go ahead.
Go ahead, Molly.
No, you go ahead.
I just want to move on to, we only have a couple more minutes. I want to ask one last question, which is, I think that Mark has introduced a cool innovation here, which is that typically when modeling the economy, we look mainly at the non-farm business sector and then government and farm. And he's introduced the healthcare sector as sort of a distinct part of the economy. My question would be, since Mark has already done that perfectly and there's nothing to improve upon it, what other sectors of the economy would it be worth trying to model separately in future iterations of this? Any thoughts? We got to give Mark some more work, guys. Come on.
Well, one thing which actually relates to something that Paul has said, we did consider a broader healthcare sector, which I think Paul mentioned in one of his slides, and we did look at that data. So you have all the pharmaceutical industry, which is a major industry. You have the retail, medical equipment, all of that. We decided not to go down that path because we weren't convinced that that it was enough different from other parts of the economy, retail, insurance, manufacturing, where it is reasonable to model it with a substitutability of capital and labor. Whereas the core healthcare sector, we believed, and again, we were basing it on literature as well as our own intuition, that was a reasonable way of modeling it, and it was enough different that to have consequences. I guess your question is, are there other sectors that are like that? Probably I would say, looking back to Baumol, government sector is one.
Anyone else? Do we want to make Mark model housing, retail, any other ideas? Great. Well, this has been just a great panel discussion, and I recommend everybody read the paper, or at least look at the slide deck, which is a very good summary of the whole thing. And hopefully we'll do this again soon. I understand we can't project if the government's going to be open in 9 days, but I do project there's going to be more conversation on this issue. So thank you everyone for joining us today.